So let me invite esteemed colleague and friend, Dr. Abu-Fadel Mazen, Director of Cardiac Cath Lab at Oklahoma University Medical Center and a long-term friend and a supporter of the Dallas CVI. Welcome, Mazen, and he's going to talk about a complex case in the theme that we have been talking earlier in the day.
Thank you. Definitely one of my favorite conferences, and thank you for the invitation. I'm going to be much briefer. I really have a pure case for you. I think the discussion has been awesome. I learned a lot. I'm sure you did too. So I'm not going to repeat any much of this. So this is a HMP of the case I'm going to present. This is literally cut from the resident note in the computer. So this is a 62-year-old male patient who presented from the emergency department of Elk City in Oklahoma, which is around 1 hour, 45 minutes west of us, so he had to be med-flighted to us. Per the wife, because he was unawake when he got there, patient was complaining of left arm pain since the morning, but then he got into an argument with his wife in the evening, and during their conversation while laying on the bed, he suddenly became unresponsive. So I think the first take-home message is be nice to your spouses. We want everybody to live long and happy life. Anyway, so EMSA was called. They came. When they came, saw him. He was in VFib. We couldn't tell if he was pulseless, but they said it's VFib, so we assumed it's pulseless. He had Glasgow coma scale of 3, so completely unresponsive. They did CPR for unknown length of time, 4 rounds of shocks and EPIs and all this, amiodarone. Then he returned to pulse rhythm, took him to the ER in Elk City, coded again over there. This was like he was in PA is what we were told. Again, CPR, EPI, etc., and then, woke up again. Intubated in the ER, hypertensive, started on levofed, and he was med-flighted with a helicopter to our hospital after they had a head CT there that did not show any bleeding. He's known to have mild to moderate mid-LAD disease, is what we were told. His EF was 40 to 45%. His private cardiologist is actually a friend and called me while the patient was en route. So these are his vital signs in our emergency room. You can see it starts from the bottom down. When he got there with epi and stuff, his blood pressure was really on 152, but a few minutes, like less than an hour later, his pressures were in the 60s, 70s on medicine, on pressors. The most significant thing is that he had a Glasgow coma scale of 11. He was, while on sedation, he was able to move all his extremities on command. So he was waking up. He was not completely brain dead or anything like that. This is EKG. There was absolutely no SC elevations. There was sinus rhythm, some extra beats, but no, most importantly, no SC elevations, poor R-wave progression, probably old anterior MI. First troponin was a little bit mildly elevated. It continued to go up later. Lactic acid is not that bad. pH, he was a little bit acidotic, of course, from all the CPR and stuff. This is echocardiogram. You can see not the best windows. EF was, by my echo colleagues, called 10 to 15%. You can see dilated LV. They didn't specifically call akinesis of any wall. They just said severely hypokinetic all over. This is with some definity, and I'm sure a lot of you can read echoes much more than I do, but definitely severely decreased EF. So came to the cath lab. Diagnostic was done. Not very obvious here, but the left main had some distal disease. There's no LAD. You can see filling left to left collaterals, no RCA, filling left to right collaterals. This is just to show you here some other views. You can see that haziness in the distal left main at the level of the ramus. That was the lesion there. It looked worse in some other views. Not much disease in the circumflex. Everything else was okay. Definitely had the right heart cath. His numbers were not that horrible, to be honest with you. Cardiac index was around 2.5. Wedge was around 14. And this is his RCA. It's completely gone. So here, many things come to mind. CTS consult, this was done just to get the heart team approach, like the guidelines say and like we should do. Our colleagues, good surgeons, but decided, we're not going to take this guy to surgery. If you can do something to help, that's great. PCI, is the anterior wall dead? Is it alive? Do we know? Is it ventricular fibrillation and he has no acute coronary issues? LV support, balloon pump, impella, none of the above, only if needed, just put a sheath or not even another sheath. What do you start with? RCA, LAD, which one is the culprit? Both have good collaterals, both you can see, no obvious thrombus in anything. So what we decided to do, actually, we said, okay, if we're going to need some LV support, we need double access anyway, so let's take a picture, see how bad that RCA is. For me, I thought after taking this picture, that probably I would like to start with the RCA. It didn't look as bad. Maybe there's a small channel there. We had a guide, you know, so it said, okay, let's go with the RCA. Went with the RCA. We were able to wire it pretty easily. We did a balloon distal RCA. This was a regular pro water wire, no fancy stuff here. I thought it might need some fancy stuff, but it did not. So I was happy, results are good, and now, you know, we took a cranial picture. Okay, there's more disease in the PDA. Since things are going smoothly, let's go ahead and try to wire that PDA and stent across it, which we did. We switched the wire over to the PDA, stented across, stented the RCA all the way back. And now the RCA looks good and nice. So I said, okay, well, we fixed that. What should we do? Maybe go to the LAD. His numbers on the right heart cath were still very good. Can you do a LV support? I mean, he has all the indications for LV support. There's absolutely no reason why you could say we don't need LV support. Probably the only reason is that his anatomy is not that complex. Definitely the RCA. The LAD, it was filling a little bit, so we said, okay, let's try to wire it. The wire kept going in that ramus, really gave us a hard time. So then we kept the wire in the ramus. We got an angled, 90-degree angled fine cross, and with a fielder wire, we were able to wire what we thought was the LAD. We went in, sure enough, it was the LAD. It was a good-sized vessel. So we went ahead and stented the LAD all the back to the left main, decided to jail the circ in this situation, post-dilated. You know, looks good. LAD is now filling, RCA is filling, no collaterals to the RCA. So we were happy with the result, and we stopped. And my fellow said, so how come you didn't do anything, any like LV support or anything? I said, you know, I just said, let's keep going. And my indication was his numbers didn't change as I was doing the intervention. And we had an access on the other side, and the impella was right there at bedside. So, I mean, if we had to open it, we can open it. And we didn't need it. So follow-up 2 weeks post-discharge, he was really feeling much better. He literally said, I feel 300% better. So he's still waiting to see if he needs an AICD. This was not long ago. So the questions here is, where's the impella? Well, I can tell you this case is in a way related to an impella, because after this case, I was called to the ER for somebody they were not able to get off the pump. So we put a CP in him, and he got off the pump. So it was related in a way. But it's difficult. I mean, one of the most difficult situations that we face is we have the data is good. If you take this guy and you put him in the data, he fits very well. It's hard to predict sometimes how people are going to do. I'm not against LV support. I actually use it and think it's very good. I'm just conflicted by when is the perfect time to use it. And this is just an example how sometimes things go very smoothly. Who will benefit and how to protect the patient is still, in my opinion, a little bit of a question. However, when you see complex cases like the ones that were just done here, I'm all for it. But in this case, I was lucky enough, and the patient did very well, thankfully. So thank you.
Thank you, Mazen.